thank our judges, Dr. Gautam Ghosh, Dr. Sutapa Ganguly, and Dr. Shumanshu Rao. Dr. Devashish Banerjee may join us, he's on his way, so he may join us also as one of the judges. So thank you very much to all the judges as well. I think it is good training for the postgraduates, these clinical meetings. Knowing how to make up the PowerPoint slides briefly and successfully, to talk to the point so that your message is delivered, and to take the question answer. So I think this is an excellent training. And thank you again. Let us start. So can we ask the first, do you have a moderator? Moderator who will call the patients one by one, who will call the candidates one by one.
Our first case is by Dr. Mousumi Khatun. She will speak about congenital ascites, the success story. The time is 6:02.
Good afternoon, everyone. My name is Mousumi Khatun, and today my topic is congenital ascites, a success story. Our patient is 7-month-old female child, informant being the mother, presented with progressive distension of abdomen since birth and facial puffiness for 10 days before admission. She was a 7-month-old female child born out of non-consanguineous marriage, presented with gradually progressive distension of abdomen since birth, which had increased substantially in last 1 month before admission. Mother also complained of facial puffiness for 10 days before admission, associated with mild swelling of feet. There was no history of oliguria, hematuria, abdominal trauma, past history of surgical intervention, jaundice, hematemesis, melena, chronic diarrhea, shortness of breath, difficulty in breastfeeding, cyanosis, fever, or any history of contact with tuberculosis. Dietary history revealed patient was on breast milk and copper formula feed with right dilution and frequency till the date of admission. Family history, antenatal history, and developmental history was normal. Immunization was up to date as per NIS. On general examination, patient was alert, conscious, playful. Facial puffiness was present without any dysmorphism. Pitting bipetal edema was there with valval edema. No skeletal or limb deformity was there. No dystrophy or yellow discoloration of nail was there. Anthropometric evaluation was normal. No wasting or stunting was there. Abdominal examination revealed soft distended abdomen with transverse slit umbilicus. Bilateral flanks were full. Fluid thrill and shifting dullness was present. No organomegaly or any palpable mass was there. Examination of other system was normal. From clinical history and examination, first we thought about congenital nephrotic syndrome. Urine analysis was done, which was normal. So possibility of congenital nephrotic syndrome was ruled out. Complete blood count was done, which was normal. LFT showed hypoalbuminemia without alteration of liver enzyme. PT-INR was also normal. Kidney function test and lipid profile was normal. Ascitic fluid analysis showed milky white fluid with cell count of 200 per cubic millimeter, mostly mononuclear cell with triglyceride content of 1124 milligram per DL. More than 200 milligram per DL triglyceride in ascitic fluid indicates it was a chylous fluid. Several imaging was done to rule out associated chylothorax or any secondary etiology of chylous ascites. All are non-contributory. Lymphoscintigraphy was planned but could not be done due to lack of facility. Upper GI endoscopy, colonoscopy, and intestinal biopsy was done, which shows no feature of lymphangiectasia. So our final diagnosis was congenital primary chylous ascites, probably due to lymphatic anomalies, which account for about 84% of all causes of pediatric atraumatic chylous ascites. Here is the etiology of congenital lymphatic anomalies. Primary lymphatic hypoplasia being the most common. Primary lymphatic hyperplasia or intestinal lymphangiectasia, Whipple-Trenaway syndrome, Turner syndrome, Milroy syndrome, and Yellowgren syndrome. From clinical history, examination, and investigation, we have ruled out last 4. Our main hurdle was to manage this patient, as there are several recommendations was there addressing management option of chylous ascites, but there is lack of clear consensus about the gold standard treatment protocol. Standard textbook recommendation is also lacking. Through this case, we would like to share our experience of managing this rare form of congenital ascites. As the child presented with huge ascites, dietary modification and medical management started simultaneously without therapeutic abdominal paracentesis. Patient was started on high protein, low fat diet with MCT oil supplementation and also received octreotide infusion at a rate of 2 microgram per kg per hour continuously for 14 days with proper monitoring. Here is the monitoring chart we have maintained during octreotide therapy for detection of any early side effect of octreotide. CBG monitoring was done 12 hourly. We have looked for any complaint of diarrhea, abdominal circumference and weight measurement done daily, and weekly LFT monitoring was done. On admission, patient has huge tense ascites with abdominal circumference of 51 centimeter. After 14 days of octreotide infusion, abdomen became soft and abdominal circumference decreased to 46 centimeter. Patient discharged in hemodynamically stable condition and kept only on dietary modification. On subsequent follow-up till date, 4 months after treatment, only with strict dietary modification, baby is doing well, having abdominal circumference of 44 centimeter without any reaccumulation of chylous ascites as evidenced by repeat USG whole abdomen. Here is the comparative picture of the patient pre-treatment and post-treatment. Here we can see significant decrease in abdominal circumference. As per our experience through this case, our take-home message is high protein, low fat diet with MCT oil supplementation and 2 weeks IV infusion of octreotide at a rate of 2 microgram per kg per hour is well tolerated and effective non-invasive management option for congenital primary chylous ascites. Here are some case reports from literature of congenital chylous ascites treated with octreotide. Here are my references. Thank you.
Follow up the case after stopping the.
Yes, ma'am.
Was there any relapse? Is it the abdominal drug?
No, ma'am. We have followed up the patient for 4. We have followed up the patient for 4 months post treatment. There was significant decrease in abdominal circumference. Initially, abdominal circumference was 51 centimeter with tense ascites, and now abdominal circumference is 44 centimeter, and USG whole abdomen revealed mild ascites. No, there was no reaccumulation of chylous.
Patient is still on follow.
And patient was still on follow.
What is the mechanism of action?
Ma'am, octreotide is somatostatin analog. It acts on transmemic vessels and causes vasoconstriction, which decreases the lymph production. It also decreases the pancreatic and intestinal secretion, which also decreases any production of chylous.
There's all taken response to the octreotide therapy, or there is any if somebody doesn't respond in external.
In refractory cases, we can thought about surgical management like transjugular hepato or any peritoneovenous shunt and or recurrent abdominal paracentesis.
Three issues. Meteorology is a lymphatic. You need a question number 1. Do you need a lymphangiography in these congenital ascites? Number 2, is there a genetic test who are predisposed, can be predisposed to this? And number 3, why only 2 weeks after I?
Okay. First, we don't do lymphangiography only for diagnosis because it is an invasive procedure. Rather, we do lymphoscintigraphy for diagnosis. No, sir, we have planned for this, but due to lack of facility, we could not have.
That's what I'm asking for. Genetic, any genetic marker.
There was no specific genetic marker for congenital primary chylomicrosis. However, it may be associated with few syndromes.
Any relapse in the next time.
It can relapse. In that case,
That's all. 1 week of.
there is several recommendations about octreotide therapy. Dose varies from 2 to 10 microgram, and duration of therapy also varies from 2 to 24 days.
Thank you. Closed.
Next, presenting the seminar is the diagnostic review of a bleeding child. Hang on.
Good afternoon, everyone. I am Dr. Sharon Jasmine. I am presenting the case diagnostic riddle of a bleeding child. Here, a 3-year, 6-month-old male child presented with a history of multiple purpuric and ecchymotic spot and multiple pruritic and dermatitic lesion at the various part of the body since last 1 year. On detailed inquiry, it revealed that the child had recurrent episode of infection like cough and cold, scalp abscess, meningitis, pneumonia, and recurrent episode of bleeding manifestations like purpuric spots and bleeding from both nostril, ear, and mouth from the early infancy. There was no history of any associated fever, yellowish discoloration, arthralgia, bleeding from any other side, or bone pain. The birth history, sibling history, immunization history, developmental history, antenatal history, and the family history was normal. General examination revealed there was a pallor, multiple purpura, ecchymotic spots, and eczematous skin lesion present all over the body, and anthropometry reveals there was stunting. Systemic examination revealed normal, except there was a 2 cm soft hepatomegaly, and there was some weakness in the lower limb as a sequelae of meningitis. To summarize, a 4-year-old male child born out of non-consanguineous marriage presented to us with a history of recurrent episode of respiratory tract infection since the early infancy and 1 episode of scalp abscess and skin and mucosal bleeding from the age of 1.5 years. Examination revealed pallor, soft hepatomegaly, purpuric and ecchymotic spots, and pruritic lesion at the various parts of the body with stunting. So, what are the possibilities? Based on the clinical profile, following differentials were thought out. Number 1, chronic immune thrombocytopenia and immune deficiency disorder, like primary or secondary. So, we further proceeded for the investigation. A complete hemogram reveals there was an anemia which was disproportionate to the blood loss, thrombocytopenia, and eosinophilia, like more than 4,000. And the peripheral blood smear shows normocytic normochromic RBC and normal WBC and eosinophilia, reduced platelet count, and normal mean platelet volume. Liver function test and coagulation profile was also normal. So, further investigation like immunoglobulin profile shows high serum IgG, IgM, and IgE. With this above finding of serum high serum IgE of more than 10,000, possibility of having hyper IgE syndrome was raised. Other investigation like serology, Roche profile, thyroid function test, ICTC, CD4 count was normal, and neutrophil oxidative index was low. Imaging like USG whole abdomen 2D echo was also normal. So the child has bleeding manifestation, thrombocytopenia, and episode of infection. Thus, we thought of a chronic ITP, but there was presence of anemia, high level of eosinophil, and high serum IgE, which goes against it. We also did bone marrow biopsy, which shows cellular reactive marrow with reduced megakaryocyte, which primarily ruled out immune-mediated thrombocytopenia. Our next question was, is this a case of hyper IgE syndrome? The child had scalp abscess, pneumonia, eczema, and eosinophilia and high serum IgE. But the child has absence of typical facial characteristics of hyper IgE syndrome, had thrombocytopenia, anemia, and raised serum IgG and IgM. The child, as the child is a male gender, there was recurrent infection, bleeding diagnosis, pruritic dermatitis lesion, multiple purpuric and thrombocytopenia, you also thought of possibility of Wiskott-Aldrich syndrome. But again, there is a normal meal platelet volume, eosinophilia, and anemia, and high serum IgG and IgM and IgE was against of it. Though the clinical profile investigation pointed towards the possibility of immune deficiency disorder, but to avoid the diagnostic dilemma and confirmation of diagnosis, we proceeded for the whole exome sequencing. That helps us to clinch the diagnosis as Wiskott-Aldrich syndrome pathogenic variant. This is the genetic report of this child. In our case, it was quite difficult to establish the diagnosis as there were some atypical findings. Extensive literature were reviewed to find out those associations, like in our case. This is the case report showing the association of Wiskott-Aldrich syndrome with normal meal platelet volume. And this is the article which also shows the association of Wiskott-Aldrich syndrome with eosinophilia. The treatment was hematopoietic stem cell transplantation is the treatment of choice. We have planned hematopoietic stem cell transplantation for this child when the high quality matched donor will be available. Till then, the patient was planned to keep on supportive management like proton oxygen prophylaxis, monthly IPIG therapy, nutrition management, aggressive management of eczema and other cutaneous manifestation. Wiskott-Aldrich syndrome is a rare X-linked autoimmune disorder with atopic dermatitis, thrombocytopenia, purpura, normal megakaryocytes, but small defective platelet. In our case, there were some atypical features like anemia, eosinophilia, high serum IgE, IgM, IgE that made our diagnostic dilemma. Here lies the importance of modern genetic study, which helped us for the diagnosis. Greater awareness of this rare disorder is the main challenge for improving the diagnosis, with an ongoing need of education of pediatrician and hematologists to whom the patient are likely to come first. These are my references. Thank you.
Genetic
Wiskott-Aldrich syndrome, pathogenic variant X-linked recessive disorder.
This is not the common type, which
No.
is CD Wiskott-Aldrich syndrome. There are some deviation or mutation.
Like X-linked thrombocytopenia can also be seen in X-linked thrombocytopenia can also be seen in this kind of variation.
In this particular variation, there may be thrombocyte. Normal platelet count.
Normal infected volume.
Wiskott-Aldrich usually have a low IgM, high IgM, normal IgM. So do we have any previous case reports of Wiskott-Aldrich with high IgM also?
No, we have searched for the literature like in our case,
Right.
but we didn't found any.
We found normal platelet volume, but we didn't found the high IgM.
We didn't found the high IgM.
So are you planning to put the case also?
Yes, I can.
Right. Was Wiskott-Aldrich syndrome? Has it usually have multiple genotypes, right? Yes, multiple genotypes are different. There are 4 basic genotypes that you find in the exome diagnosis. Thus, every genotype has a different phenotype. That probably is the problem in this group.
That may be a probability.
Yes.
As there was a many kind of genotype in case of Wiskott-Aldrich syndrome. But in our case, we found that there was a many variation in
The gene that are
gene.
Yes, one of them.
Was gene. With the
There are 4 groups. Anyway, the issue is that there are 4 groups that are subtypes, and they have different phenotype in question. Maybe.
We find after reports.
That genotype. This genotype.
It's specific.
not like in our not similar to our case, but we have found some different phenotypic features in that genotype also.
Correlation was not there.
The next presentation is the enigma behind macrophage activation syndrome.
Good afternoon, everyone. This is Dr. Purvali Ghosh presenting the case, the enigma behind macrophage activation syndrome. We have this 10-year-old sick-looking child who presented to us 6 months back with fever and pain abdomen for 2 months prior to admission. The fever was low-grade and intermittent. The pain abdomen was generalized and non-specific in nature. She also had generalized malaise, decrease in appetite, bilateral lower limb swelling. She had developed hypo and hyperpigmented macules on face and bilateral lower limbs prior to admission as shown in the images. All the relevant negative history has been compiled in this slide. She had decrease in appetite. There was no similar episode in the past. She did not have any previous history of drug intake. Birth history, feeding history, developmental and immunization history were within normal limits. There is no similar family history present. On examination, the patient had pallor, bilateral pedal pitting edema, pulse was tachycardic, BP was normal, temperature was raised, and bilateral cervical, axillary, and epitropical lymph nodes were palpable. Weight for each was less than 3rd percentile, height for each was within 3rd to 10th percentile. On systemic examination, the oral ulcer was present in the hard palate. Liver was 2 cm palpable below the right costal margin, firm, tender, with well-defined margins. The span was 8 cm. Spleen was 1 cm palpable below the left subcostal margin. The respiratory system, cardiovascular, and central nervous system examination were within normal limits. So in summary, we have a 10-year-old child who presented with fever, pain abdomen for 2 months, hypo and hyperpigmented macules in the face and bilateral lower limbs, anemia and bilateral pedal pitting edema, generalized lymphadenopathy, hepatosplenomegaly, and ulcer on the hard palate. So the possibilities considered were leukemia, tuberculosis, connective tissue disorders, and infectious mononucleosis. The basic investigation revealed low hemoglobin and low platelet count. The peripheral blood smear showed microcytic hypochromic anemia and isocoagulocitosis with no atypical cells. Due to the lack of atypical cells in the peripheral blood smear, bone marrow was planned to rule out leukemia completely. Liver function test showed raised SGOT and SGPT. LDH was raised, DCT was positive, ESR was raised, and CRP and procalcitonin were within normal limits. Urine also showed the presence of 1+ albumin. The patient was started on IV antibiotics while further reports were pending. Chest X-ray and USG whole abdomen was normal. Mantu COVID antibody and viral capsid antigen came out to be negative. GLCP did not detect any nucleic acid, MTP nucleic acid. So tuberculosis and infectious mononucleosis were not considered as a diagnosis. Bone marrow was planned, but the patient was deteriorating further with a high grade of fever and subsequently falling ESR. So HLH was considered as a possibility. Serum triglyceride and serum ferritin were sent, which came out to be raised. As planned, the patient went for bone marrow biopsy, which presented with a surprise. Aspiration showed hemophagocytosis, and biopsy showed reactive marrow with no blast cells, thus ruling out leukemia. So we had fever, splenomegaly, hypertriglyceridemia, hyperferritinemia, and hemophagocytosis, thus clinching the diagnosis of HLH. Triggered the HLH. Keeping in mind the possibility of collagen vascular disorder, ANA and ANA profile was set. ANA was 4+ core speckled. ANA profile revealed RNP and Smith strong positive and dsDNA positive. 24-hour urinary protein was raised. C3 and C4 were reduced, and lupus and anticoagulant and ANCA were negative. After ruling out leukemia, TB, and infectious mononucleosis, connective tissue disorder was another possibility. We considered the 2019 Euler criteria, whereby ANA titer was 1:160, fever gave a score of 2, oral ulcer gave a score of 2, thrombocytopenia gave a score of 4, low C3 and C4 gave a score of 4, positive anti-Smith antibody gave a score of 6. Thus, the total score was more than 10. Diagnosis of SLE was thus confirmed. So the final diagnosis was SLE with mass as the initial presentation. This is the 2019 Mueller-ACR criteria which was used for diagnosis. After diagnosis of the treatment, patient was started on pulse injection methylprednisolone followed by oral prednisone and hydroxychloroquine. After 5 days of therapy, patient improved clinically with rising ESR and decreasing ferritin. Renal biopsy showed focal lupus nephritis class 3, because of which the first dose of pulse cyclophosphamide was given according to NIH protocol. The patient again developed high-grade fever, cough and bilateral crepitations. Peripheral blood smear showed high TLC and a leukoerythroblastic picture. There was raised ESR, ferritin and CRP with negative blood and urine culture. Chest X-ray showed peripheral consolidation. Here are the two X-rays showing the peripheral consolidation. Considering it to be infection-induced, antibiotics were upgraded with a reduced dose of steroid. Patient initially responded with clinical improvement and decreasing counts and was appropriate for a period of 3 days. However, within 5 days, the patient again developed high-grade fever with cough, crepitations worsened, and chest X-ray showed worsening of pneumonia. Because of superadded bacterial infection or disease flare, or the patient had again gone into mass. Blood counts were normal, but platelet was reduced with falling ESR and raised triglyceride, CRP, and ferritin. Echo showed pericardial effusion. CECD showed patchy consolidation in the lung fields. There was no improvement even after giving antibiotics. Considering it to be another episode of mass, the patient was given IPIG over 3 days. Patient improved clinically after this. So this patient was finally diagnosed as a case of SLE with mass as the initial presentation with a challenging treatment course because of the recurrence of mass. The patient was discharged after the second dose of cyclophosphamide and was planned for pulse therapy of cyclophosphamide for a period of 6 months with continuous hydroxychloroquine and a tapering dose of steroid over 9 months. Patient at present has completed the 6 cycles of cyclophosphamide, was put on MMF and is doing well. Macrophage activation syndrome has a common association with systemic onset GIA. The association of pediatric mass with pediatric SLE is rare, the incidence being 0.9 to 4.6%. Till date, only 94 cases of SLE has been reported which has association with mass, and among them, only 9 such cases are there when mass is the initial presentation of SLE. Since mass is a life-threatening complication, it requires urgent diagnosis and intervention, and thus it is imperative to understand the difference between mass and disease flare. A similar case was reported where SLE presented with mass as the initial presentation in a 14-year-old child who was treated with IVIG and cyclosporin. There is also a case reported where a 14-year-old child had 3 episodes of mass during the course of the treatment. The excerpts of the case reports discussed are here. So the take-home message is the pediatric SLE can present as mass during the initial phase. Mass should be suspected in patients of any connective tissue disorder presenting with high-grade fever, hepatosplenomegaly, generalized lymphadenopathy, hyperferritinemia, hypertriglyceridemia, and not responding to regular treatment, even in SLE. For the treatment of mass, IVIG and immunomodulators can be used apart from IV methylprednisolone, and patients can go into multiple episodes of mass throughout the disease course. Thus, it is essential to not only treat the mass but also the primary disease behind it. These are my references. Thank you.
In the second course of worsening of the different concern, how can you differentiate infection from mass itself?
So because
IVIG may work in both, maybe viral pneumonia.
yes, sir. If the infection, just like in our case, we had a dilemma whether it was a flare or infection. We saw that the like mass versus viral infection. Mass versus infection. In infections, just like in first case, we had raised counts, but in mass, the counts will decrease, and also there will be decrease. Particularly, there will be thrombocytopenia, and CRP and ferritin will be raised. Also, there will be reduced, like falling ESR. That yes, sir. Yes, sir. ESR was initially high and there was a rapid falling of ESR. So that made us suspect mass first time.
Do you have a low albumin?
Sir, low albumin, initially we had in the first blood picture. Yes, sir.
SLE stage.
Yes, it was done, but
So,
Sorry. Very clear. You said hyperpigmented vacuum. Do you agree? Right. You said pitting edema.
Yes, sir.
Does it explain by SLE?
So bilateral pitting edema could have been because of the low albumin that was initially present, which was induced by like the patients had counts which were initially high also, so the low albumin can.
Hypoalbuminemia, is it due to SLE?
So because of any inflammation, albumin can reduce. So
Okay.
since our patient presented with mass initially, so that can explain.
There are only two issues. The child had multiple.
Yes, sir, 2 episodes of.
Does it make the prognosis of SLE in long run worse?
Sir, I haven't found any case reports like telling the prognosis. It might. It may lead to bad prognosis.
Last, this is a question, of course, I think is validated by the full. Is it this child can meaningful lupus? Chance of getting lupus also.
Because of serum albumin reduced.
For this person, right? Lupus. Thank you.
Thank you, sir.
This child.
Patient.
This is the same child.
Yeah.
Good.
Next, the next presentation is mysterious fat loss in the case of autoimmune disease.
Good afternoon, everyone. Myself, Dr. Sandeep Ghosh. I am presenting my case on mysterious fat loss in an autoimmune disease. Here, the 11-year-old male child presented to us with failure to thrive, with short stature and senile low, with loss of fat over the temporal region. The child had recurrent oral ulcer over the and also ulcer present over the nose and perioral region on and off since infancy. The child also had severe angular stomatitis. The child also presented to us with extensive perineal infection and solid knee joint since last 2 months. The child had a past history of acute encephalitic-like episode at 2018 with right-sided hemiparesis, aphasia, and convulsion with prolonged fever. The child was developed pancytopenia at that time. The child was treated with ATD and steroid at that time, and apparent recovery was there. The CT vein of this child at that time surprisingly diffuse intercerebral calcification and infarct in the right putamen and left frontal region. These are some negative history elaborated here, like no history of chronic illness like diarrhea, polyuria, decreasing in food, or perinatal complication like delayed crying. Developmental history and birth history being normal. On general examination, we found the child had loss of fat over the face, temporal fossa with prominent muscles that suggestive of lipodystrophy. Pallor and icterus was present in this child. The face is somewhat like dysmorphic, procedural looking. Angular stomatitis present, oral thus also present in the oral cavity. The child had scarring, blister, and rash present over the face, over nose, perioral region, and over the bilateral eyebrows with extensive periangular infection. There is no Gottfried or heliotrope rash present in this child. Anthropometric measurement shows the child had short stature and standing. On systemic examination, the child had asymmetrical fat deposition over the abdomen and liver palpable 3 cm below the right costal margin with soft inconsistency. The other systemic examination being normal. Summarizing my case, the child with failure to thrive, senile low, facial lipodystrophy with recurrent mucocutaneous infection from childhood, also having a past history of acute encephalitis-like syndrome, right-sided with right-sided hemiparesis, aphasia, and convulsion that treated with ATD and steroid, and apparent recovery was there. And now the child presented with extensive periangular infection with oral thrush, blistering and scarring lesion all over the face and body with solid knee joint. So all these events are not OCDs, so all these events are multiple pathologies or can be explained by single pathology. So moving to my next investigation, the CBC shows pancytopenia-like picture during admission. The LFT suggests transaminitis and increased serum alkaline phosphatase and KFT being normal. On further investigation, the direct Kuhn test came positive with 4+ ANA positive, 1:160 titer, and anti-DSDN also positive. The child also had low C3 level and normal C4 level. In the view of ANA positivity and DSDN positive and low complement C3 level, the patient was primarily diagnosed as systemic lupus erythematosus. The routine urine analysis shows the presence of albuminuria and hematuria, and 24-hour urinary protein suggests a nephritic range proteinuria. So the renal involvement is suspected in view of SLE, and renal biopsy was done thereafter, which shows focal lupus nephritis class 3. So, according to new ACR and ULR criteria for classification of SLE, our case is diagnosed as systemic lupus erythematosus with lupus nephritis class 3, having hematologic, neuropsychiatric, mucocutaneous, musculoskeletal, and renal involvement with ANA and DSDNA positivity and low C3 count. Now, the MRI brain of this patient revealed diffuse calcific, symmetrical calcification, symmetrical confluent calcification involving the bilateral lentiform nuclei, thalamus, paraventricular, and cerebral gyri, with involvement of bilateral cerebral hemisphere. The hyperparathyroidism is also ruled out in this patient with normal IPTs and calcium level. Now, the question is SLE with interstitial calcification. Is this feature is consistent with SLE? And is there any relation between this interstitial calcification with neurological manifestation of SLE? So here is some case report. So though the interstitial calcification are not a consistent feature of the SLE, in the literature, few cases have been reported before, and thus interstitial calcification is an unusual manifestation of SLE. And after reviewing the existing literature, we found that the several patients with calcium deposition never had any neurological manifestation, and it has no direct role in clinical expression of the CNS lupus. During hospital stay, the patient is treated with IV methylprednisolone for 5 days and then is shifted to oral prednisolone and hydroxychloroquine also given. The patient received IV cyclophosphamide monthly as a pulsatility dose for 6 months, and thereafter the immunotherapy added as a steroid-sparing agent with gradually favoring prednisone. The patient improved drastically and with above treatment, and improvement was satisfactory. During the follow-up after 2 months from the discharge, as the child is gaining weight, the bilateral symmetrical partial lipodystrophy over the temporal region of the face became prominent. There was no such lesion elsewhere in the body, and other systemic examination was unremarkable. So patient was diagnosed as having acquired partial lipodystrophy over the face. So acquired partial lipodystrophy in the case of SLE, is there any association between these two? So here is a case report of Barraquer-Simon syndrome in systemic lupus erythematosus. The Barraquer-Simon syndrome is an acquired partial lipodystrophy, can be associated autoimmune conditions like SLE, dermatomyositis. This syndrome also have low level of C3 complement is almost universally associated with it. As in our case, the low C3 level also enforces our diagnosis. All these features, the patient clinically and laboratory investigation, the Barraquer-Simon syndrome fits in our case. So our case, the child is diagnosed as the Barraquer-Simon syndrome in a background of SLE. As no such treatment is available currently to halt the progression of this lipodystrophy, and its progression mainly depends on the underlying associated renal disease. And managed in the line of SLE, and will see the course of the disease. Though SLE is more common in girls, in our case, the boy is diagnosed with SLE with all systemic manifestations, along with some unusual rare manifestations like acquired partial lipodystrophy and interstitial calcification. The Barraquer-Simon syndrome, which is an acquired partial lipodystrophy in association with SLE, as in our case, is a very rare phenomenon, and it's been reported only few literature before. The treatment of this lipodystrophy is limited to cosmetic surgery and dietary management. The presence of diffuse interstitial calcification in SLE, as in our case, is also very unusual finding, and few cases have been reported in literature with similar findings. These are my references. Thank you.
The child had autoimmune encephalitis and then the child presented with lipodystrophy. And then presented lipodystrophy. So what made you suspect SLE in this particular child?
The child, when he presented to us, child has oral ulcer, the rash is present over the faces. After controlling phase of the rashes are suspected primarily as DA. So we suspect the child may have the underlying SA. So we sent for ANA profile, and it came 4+ positive with DSGN also positive. Oral ulcers. And also when the child after the second time last time admission, child had hematuria and nephritis is 1400.
Have you done a protein creatine ratio at the onset during diagnosis of SLE plus nephritis? Generally 24 hours protein, na?
Yes.
Was there a PCR was done? Because your urine dipstick was 3+, that is similar to nephrotic range. Your 24 hours protein is coming less.
Yes.
So if there is confusion, you can always do PCR.
PCR actually
You have sent only 24 hours creatine along with that.
no sir.
We need to send both together.
Actually,
Possibly some laboratories are not doing it. Maybe
in our hospital, ACL is not having.
no, not PCR, PCR.
PCR.
So we need to send urine creatine 24 hours along with protein. Is there any implication?
Yes, sir. It should be sent.
Why? Why? How is the child now in partial remission, complete remission, not in remission? What is the current PCR or
Child is remission and even here.
what is the current PCR or 24 hour protein?
Negative. Urine, protein and blood both are negative.
In CR, complete remission.
Positive.
You said IPGMER is a facial abscess, right? Methicillin resistant
Yes, sir.
Staphylo aureus.
Yes, sir.
In the abscess in the face.
Yes.
With a really
So not this in perianal culture of perianal.
is it so common in lupus nephritis?
No, sir. No, sir. It's not covered.
It is happening. Some immunology. This is not common in lupus nephritis.
Yes, sir.
Why did it have many effects? We think about
Patient also have the primary immunodeficiency since
what
with low complement.
low complement does it put into every cell? Some other group of organs. Anyway, do you suspect anything else? Does it happen in lupus nephritis?
Usually, once they are on immunosuppression, they can be prone to different type of infection. But
Was this child treated?
Yes, sir. This which
And the abscess appeared before treatment or?
before treatment actually.
Thank you.
The next case would be sui generis manifestation of a hypertonic dot. Sui generis manifestation of a hypertonic dot. The case is sitting in front of it. Dr. Shukonado.
Good afternoon, everyone. Myself, Dr. Shrikanda Datta, I'm going to present a unique manifestation of a hypertonic toddler. This 3-year male presented to us with complaint of increased mobility of bilateral ankle, wrist, and small joints of limbs since 1 month of age and has never achieved the ability to stand due to bilateral lower limb weakness. He also has complaint of looseness of limbs, inability to fully extend bilateral knee joints and elbow joints, gradually progressive thinning of limbs, inability to rise up from sitting position, creep and crawl, and characteristic rash noted on the extensor surface of limbs since infancy. This is the picture which has depicted whatever I have described before. There was no history of muscle pain, cramps, or passage of reddish-colored urine following exercise, diminished fetal movement, breathlessness, palpitations, dysphagia, dysarthria, ptosis, impaired vision, seizure, or any bladder or bowel movement. All the other history, including the antenatal and the birth history, were within normal limits, apart from a third-degree consanguinity in the parents and a motor developmental delay. The general survey and anthropometry revealed a moderately stunted and severely wasted stature. The head-to-toe examination revealed keratosis pilaris, soft velvety skin, and absent major and minor trees on palms and soles. There was bilateral hyperlaxity of distal joints, bilateral proximal joint contractures, marked thinning of musculature of limbs, along with prominent calcaneum. The CNS examination revealed hypotonia, diminished power in all four limbs, preserved jerks, and bilateral flexor plantar response. The musculoskeletal system examination revealed thinning of all musculature of limbs without any focal atrophy or hypertrophy. So these are our positive findings. Gross motor delay, hypotonia with gradually progressive weakness and diminished anti-gravity muscle movement pointing towards a motor unit dysfunction, that is peripheral hypotonia. So we can suspect a neuromuscular disease. The next job is to localize the site of lesion. The jerks were preserved. Plantar response was bilaterally flexor. There is also contracture and hyperlaxity of joints, which is generally found in congenital muscular dystrophy and Ehlers-Danlos syndrome. There was also thinning of musculature, whereas no focal atrophy and hypertrophy of muscles, which rules out dystrophinopathies. Absence of myalgia and cramps does not favor metabolic or inflammatory myopathies. Absence of myotonia in the child or mother points against congenital myotonic dystrophy. There was no history of fluctuating weakness, which is generally found in neuromuscular junction disorders, mitochondrial myopathies, no history of cola-colored urine following exercise, which rules out metabolic myopathies, no evidence of sensory loss, and thus this is not a case of peripheral nerve involvement. There was absence of tongue fasciculations or areflexia, which is going against SMA. So to summarize, we have our positive and negative findings. The onset is insidious from early infancy and progress is chronic and slowly progressive. Pattern of weakness is mainly involving the proximal weakness, but no facial, bulbar or ocular palsy. There was a third degree consanguinity among the parents, proximal joint contractures, distal joint hyperlaxity and keratosis pilaris, but absence of cardiac or respiratory involvement, rash, cataract, or organomegaly. So this is probably a case of neuromuscular weakness with the neuroanatomical site of lesion being muscle. The possibilities are congenital myopathy or congenital muscular dystrophy, like limb girdle muscle dystrophy or Emery-Dreifuss muscle dystrophy. The basic investigations, initial imaging were within normal limits, the X-ray skeleton short survey, as well as the baseline serum calcium, phosphorus, parathormone, and vitamin D3 were normal, ruling out any skeletal abnormalities. Also, there was no evidence of any hip dislocation. A normal thyroid profile excluded congenital hypothyroidism as a cause of hypotonia. From history and clinical examination, we are suspecting a neuromuscular disorder. Cause has been localized to muscle. The muscle enzymes were sent. LDH was found to be elevated. A marginally elevated CPK is suggestive of a dystrophic process, strong possibility of congenital muscular dystrophy. MRI brain, spinal cord, MRI pelvis, thigh, and both legs were subsequently planned. Meanwhile, ophthalmological examination done revealed no cataract, which is going against myotonic dystrophy. ECG was normal, which rules out cardiac involvement. Hearing and vision was normal. MRI brain, cervical, and dorsolateral spine was also normal. Whereas MRI pelvis, thigh, and leg muscles showed features of myositis. Subsequently, we planned for an echo 2D to finally rule out a cardiac muscle involvement. We also plan to go ahead for EMG and NCS of all 4 limbs for our patient at our institute. A normal echo ruled out cardiac involvement, which is generally present in Duchenne muscular dystrophy and Emery-Dreifuss muscular dystrophy. NCS was normal, whereas EMG showed polyphasic spikes. Thus, the clinical pictures and relevant investigations points towards a diagnosis of congenital muscular dystrophy, more likely due to a genetic cause, which is to be finally determined. Thus, to come to a conclusion and to clinch the exact diagnosis of the patient and solve this diagnostic dilemma, we sent a peripheral blood sample for targeted clinical exome sequencing. The results came, and this clinched the diagnosis of Ullrich congenital muscular dystrophy, pathogenic variant due to collagen 6A3 gene deletion. This is a very rare entity, and other presenting features were kyphoscoliosis, spinal rigidity, and failure to thrive. Deteriorating respiratory function is the leading cause of death in UCND. The treatment is basically conservative, and respiratory failure will require an early BiPAP and NIV support. There is an emerging interest in neuromuscular imaging as a supplementary guide to diagnosis of this case. There is a limited role of EMG and muscle biopsy in diagnosis of neuromuscular disorder in modern era. Clinical exome sequencing and targeted gene panel testing have revolutionized the diagnosis of neuromuscular weakness disorders. These are my references. Thank you.
What is the prognosis of this case?
Ma'am, UCMD in particular for this case, UCMD is a more severe variant. Prognosis is worse than the other variants.
Genetic counseling is done?
Yes, we have done the genetic counseling, and if the patient can afford, we will. This is basically autosomal recessive. So for further, in case they take another, the genetic counseling is therefore necessary and it has to be done.
What's the height of the child?
Height of the child was this is 98 centimeter. The height was this moderately stunted.
The score is between the
Third to 50.
30 country. Less than 30 country.
Percent
It's a normal of content
stunted.
between third and 50th.
No.
Okay.
It's okay.
That's correct. You know what a new drug. It's a very good height for Duchenne muscular dystrophy. Not steroid, something more. What is that? You will use it. Can you use it that? That's not available in Singapore. It is being available on public. Is it the same drug can be used in this particular? That's a very good case. Hello.
Actually, the drug that has been designed for Duchenne muscular dystrophy, I can't exactly remember the name right now. That is exactly acting on the truncation of genes.
Thank you.
The name, case is diagnostic colossus.
Crowd.
Good afternoon, everyone. I'm Dr. Shreya Haldar, and I'm here to present a case of diagnostic conundrum in a case of neuroregression. We had a 4-year-old female patient who had presented to us with loss of ability to walk and speak, with repeated episodes of fall and abnormal eye movements. She was a 4-year-old girl who was born of third-degree consanguineous marriage. She had achieved the milestones of walking and speaking bisyllable words at par with age, but she always had a tendency to fall while walking, which started around 18 months of age. And gradually, she also started losing the ability to walk, stand, sit without support, and even speak, which also started around the same time. The child can now only sit with support and still has a tendency to fall while sitting and cannot speak even monosyllable words. There's oscillating movement of eyeballs, which the mother has noticed in the child when she fixes her gaze at a particular object, and that has started around 6 months ago. There's, however, no history of convulsions, abnormal movements, difficulties in feeding or breathing. There's no bladder bowel involvement, no disturbances in sleep, no complaints of recurrent infections, loss of weight, recurrent episodes of vomiting or headache. Birth history and family history were insignificant in the child. Developmental history was normal up till 11 months of age. Anthropometry was also normal, and head circumference was normal in our child. Vitals were stable. General and regional examination was non-contributory. The patient was alert, conscious, unable to speak, follows objects with routine playful activity. Cranial nerve examination showed that bilateral pupils were reacting to light. Fundus examination was normal, with no cherry red spots and no other abnormality found. There was no papilledema, ophthalmoplegia, or ptosis. All of the cranial nerve examinations were also normal. There was no atrophy of muscles, no cuff enlargement or asymmetry was noted. However, there was hypertonia with significant spasticity in all 4 limbs. Power was 2/5 in bilateral lower limbs and 3/5 in bilateral upper limbs.
Deep tendon reflexes were all 3+. There was no bradykinesia, tremor, joint swelling or pain, no contractures, and no chorioathetoid movements. Bilateral plantar reflex was extensive. The sensations of touch, pain, pressure were all intact, and cerebellar examination showed truncal ataxia and nystagmus, but the child could definitely reach objects with her hands. Systemic examination was also within normal limits. So, to summarize, we had a 4-year-old female child born of third-degree consanguineous marriage. She had achieved normal developmental milestones till 11 months and also experienced a tendency to fall, which started around 18 months of age, along with neuroregression at the same time. The child can now only sit with support. Her language skills have all been lost. She initially had hypotonia of all 4 limbs that gradually progressed to spasticity. She had no convulsions, no extrapyramidal features, organomegaly or ghost features, and no neurocutaneous manifestations. She had a normal head circumference. She has spasticity and exacerbated deep tendon reflexes. Truncal ataxia and nystagmus was also present. So we can say it's a case of neuroregression with late infantile onset. It's a chronic progressive encephalopathy. It's a white matter disease with no extraneural manifestation. There's no family history and cerebellum is also involved. Thus, from this, we can rule out gray matter diseases and storage disorders. So up till now, our differentials can be infantile form of metachromatic leukodystrophy, infantile neuroaxonal dystrophy, vanishing white matter disease, ataxia telangiectasia, and ataxia with oculomotor apraxia. So we proceeded with routine investigations, which showed that routine CBC and LFT were normal. So we ruled out the possibility of ataxia with oculomotor apraxia because in this disorder, serum albumin is low and lipid profile is deranged, which was not so in our case. ICTC of mother and child were non-reactive and lactate and pH levels were also normal. So we ruled out mitochondrial diseases and acquired immunodeficiency encephalopathy. We proceeded with MRI brain, which showed mild cerebellar atrophy and no other findings. EEG sleep record showed paroxysmal high voltage sharp wave discharges, and NCD showed motor axonal neuropathy. From both the clinical examinations, history, as well as imaging findings, we could not rule out the possibility of a cerebellar disorder being present. So one of our diagnoses was ataxia telangiectasia, but in our case, our patient had no history of recurrent sinopulmonary infection, no telangiectasia, there was no tremors or hypotonia in our patient. Another important consideration was vanishing white matter disease, which had many features suggestive of this disorder in our patient. But there's always a precipitating stress factor in this disease before acute neurological decompensation, which was not present in our patient. Infantile neuroaxonal dystrophy was another consideration which had both white matter affection as well as cerebellar affection, and our patient had many features suggestive of this disorder. And a very important consideration in our case was metachromatic leukodystrophy. Our patient had almost all the findings suggestive of this disease, but the only problem was that MRI brain should have shown cerebral white matter dystrophy with tigroid appearance and leopard skin appearance, which is very characteristic in MLD. But our MRI finding had no such finding. So we had a diagnostic dilemma between metachromatic leukodystrophy and infantile neuroaxonal dystrophy. So we decided to go for genetic testing. And that revealed a homozygous missense variation in exon 15 of the PLA2G6 gene, which was diagnostic of infantile neuroaxonal dystrophy. It's an autosomal recessive neurodegenerative disorder with early symptomatic onset and rapid progression of psychomotor regression. It falls under the spectrum of neurodegeneration with brain iron accumulation. There's no effective treatment at present for this disorder, and little literature is available on this disease. So it's important to provide accurate genetic counseling for families with this disease. This was the only disorder in our differential which had almost all the clinical findings, history, as well as imaging findings that matched with our disease. For example, the child was asymptomatic at birth with normal developmental milestones. It had a late infantile onset. There was truncal hypotonia with neuroregression, and there were no convulsions present in our child, but still EEG was suggestive of epileptiform discharges, and MRI also shows cerebellar atrophy, which is typical of this disease. These are the case reports which we have found, in which there were children presenting with neuroaxonal dystrophy, who had almost the same clinical presentation as our patient. These are my references. So we had a very rare disorder of infantile neuroaxonal dystrophy with typical features. Thank you.
Very interesting is we have Must thank you, the team who worked out. Anyway, I have only one issue regarding clinical examination. You see, this is a white matter disease, and it started with hypotonia. Usually,
Yes, sir.
yes, why?
So because cerebellum is also involved in this case, so maybe that's why it had more hypotonia, which is progressing to spasticity when white matter is also gradually involved.
That's cerebellum. Is it a feature of the white matter?
So white matter disease is mainly present with spasticity, but
Initially,
in
okay. Was that a serious course? There was no signs of spinal shock.
no, sir.
Absolutely.
No, sir.
Right. And how do you manage this child now?
So we have managed.
Other than physiotherapy?
No, sir, we have only conservative management for this child, but the child does not need any conservative management such as present, because the child can take oral feeds properly and there's no breathing problems as well. But there are no any other treatment available at present for
Yes,
this.
it is 4 years now.
Yes, sir.
So it is very good brain, isn't it? Absolutely, right? He doesn't have a problem in payment, but he's not cooperating well. Slowly, that's the problem. Activity that we can be global. Nobody. Thank you.
The same mutation reported earlier in some patient.
Yes, sir. Yes, sir. The same mutation was present in other cases as well, PLA2G6 mutation, and this mutation can also be found in other cases, for example, dystonia.
Same exon 3 mutation.
Uh,
Report is likely pathogenic and not pathogenic. So in the same report they write, this is the reference. The same mutation was, or the variant is found in these patients. Was it reported earlier?
yes, sir. No, sir. It was reported in other exons, not in the same exon.
The example of the slide
Yes, sir.
side.
Yes,
So
sir.
have you done the parents?
No, sir, not.
The next case is the unusual case of monkey market.
Good afternoon, teachers. Myself, I am presenting a neonatal case that is an unusual case of neonatal heart failure. Look beyond the heart. A 10 days old neonate came to us with the features of abdominal swelling and respiratory distress along with feeding difficulties. For search for antenatal history, it showed that 24 years old primigravida mother, married for 2 years out of non-consanguineous marriage, having spontaneous conception, there is no history of any maternal complication, no history of fetal loss or neonatal death. Mother received injection tetanus toxoid along with iron, folic acid, and calcium tablet adequately. Serology was negative. Antenatal immunity was not available as the baby was outborn. Baby delivered by NECS at 38 weeks of gestation. Girl baby 3.1 kg birth weight. Outcome was not available. Baby had 4 cries just after birth and developed respiratory distress. Admitted to the SNCU of that hospital. Managed conservatively with free flow oxygen. On day 4 of life, baby developed neonatal jaundice and received phototherapy for 24 hours. Then discharged on day 7 of life from that hospital. Now the child presented to our hospital at day 10 of life with progressive abdominal distension, feeding and difficulties and respiratory distress. Admission weight was 3560 gram, that is 15% weight gain since birth. On admission, the baby was lethargic, CRT was less than 3 seconds normotensive. Examination findings depicts the baby having respiratory distress with tachycardia and gallop breathing, and prerectal saturation was between 80 to 85% in room air. Liver was palpable 7 cm below right costal margin and it was firm. No other organomegaly noted. Other systemic examination reveals normal. Now the baby was put on NIV due to distress and kept 10 p.m. and IV fluid started. Intensive phototherapy also started for hyperbilirubinemia. Chest tested revealed there is a features of pulmonary edema and cardiomegaly. Initial screening echo shows IVC dilatation along with RA and RB dilatation, moderate tear jet, ejection fraction 35%. Lung USG was done, which reveals the features of alveolar interstitial edema, that is the pulmonary edema. And so IV fluid have been started. This is a chest X-ray of this baby showing cardiomegaly along with pulmonary edema, and this is the lung USG which showed B lines that is suggestive of pulmonary edema. So our first impression was it is a case of congestive heart failure. So what may be the cause for this congestive heart failure? There are some common causes of congestive heart failure in newborn age, which can be divided into cardiac cause, systemic cause, and vascular cause. In cardiac cause, there may be congenital heart disease, cardiomyopathy, or arrhythmia. Systemic cause, there may be anemia or sepsis, or vascular cause, that is AV malformation or hemangioma. Now started evaluation of congestive heart failure. Routine investigation was done, which was almost normal, except there is hyponatremia and blood gas shows mild metabolic acidosis. On admission, ECG was in sinus breathing. Evaluation of jaundice revealed reticulocyte normal. Bilirubin was more than therapy cutoff. Baby's blood group was B positive. That is no ABO or RH incompatibility because mother having also B positive. D6PD level shows not deficient, but exceptionally high TSH, that is 47 milli-international unit per liter. Echocardiography revealed there is a moderate pulmonary arterial hypertension along with difference in the aortic diameter proximal and distal to the origin of the celiac artery that indicates a high flow lesion. Abdominal ultrasonography was done along with Doppler for searching of hepatomegaly. At it showed the massive hepatomegaly and multiple hypoechoic nodules covering the entire liver. USG brain showed no AV malformation. For elucidation of the hepatomegaly, we have done triple phase contrast CT abdomen, and it showed pre-contrast CT abdomen hypodense hepatic nodules. Arterial phase showed hyperintense hepatic nodules, and total venous phase shows centripetal filling of the hepatic nodules. All these features are suggestive of a hepatic hemangioma. So the evaluation of these hepatic lesions, World Journal of Pediatrics, Clinical Pediatrics given a differential diagnosis of the hepatic hemangioma. I have simplified the chart that if there is a presence of hepatic lesions having hyperenhancement with vascular invasion on CT or MRI, it can be of three types: singular or multiple or no visible liver parenchyma. If it is a single lesion, it can be neuroblastoma or hepatoblastoma. It can be, if it is multiple, then it can be neuroblastoma, hepatoblastoma, or multiple infantile hepatic hemangioma. We have done USG adrenals and urinary BMA which came normal, and serum AFP level was also normal. No visible liver parenchyma was noted in our case. So thyroid hormone evaluation has been done. It shows there is a high TSH level. So it is a case of diffuse infantile hepatic hemangioma. If the thyroid hormone level is normal, then it can be a case of Casadas-Merit phenomenon or angiosarcoma. Both are very rare in newborn period. To confirm our diagnosis, histopathology is considered, but in our case, it is not considered after consulting with the gastrosurgery, as it is a very diffuse hemangioma and having risk of hemorrhage. There is no cutaneous hemangioma and stridal nodule. So our final diagnosis is based on it is a congestive heart failure along with presence of hypothyroidism, along with presence of multiple enhancing hepatic lesions. So it is a case of diffuse infantile hepatic hemangioma. Specific management has been started with propranolol at 2 mg per kg per day and thyroxine at 15 microgram per kg per day. On day 38 of life, this tablet enalapril was added as the baby had still in cardiac failure, and prednisolone also had been started initially with 2 mg per kg per day, but it had to be escalated to 5 mg per kg per day as there was no optimal improvement. Repeat echocardiography repeat after 10 days of combination therapy. It showed there is improvement in the ventricular function and also the reduction of the pulmonary pressure. Repeat ultrasonography of the abdomen showed reduction in the hepatic nodules and decreased flow in the liver. Repeat thyroid stimulating hormone showed reduced to 4.5 milli-international unit per liter. Prednisolone dose then tapered gradually and stopped over a period of 3 weeks. Then baby planned for discharge and asked for regular follow-up in OPD. At 3 months of age, baby came for follow-up. There was no features of heart failure. Liver was 3 cm palpable below the right costal margin. Screening ultrasonography revealed there is reduction of the hepatic nodules and decreased blood flow. There are treatment options which is not mentioned in any standard textbook, but I have reviewed some literature and where some treatment options are given. That's the drugs may be used like prednisolone, propranolol. Other medical therapy are under trial. Interferon alpha, vincristine or vinblasting, and cyclophosphamide. Embolization and ligation can be done. and rejection of these nodules along with liver transplant when the medical management failed. So the hepatic hemangiomas are the benign vascular tumor of liver and it can be asymptomatic or self-limiting, but life-threatening complication may occur. Mortality rate is very high if there is a presence of complication. There are three variants: focal, multifocal, and diffuse, often associated with dermal or laryngeal hemangioma. But infantile hemangioma must be confirmed by positive immunostaining for GLUT1 that helps to differentiate from the other vascular anomalies. The prognosis of this infantile hemangioma is very poor when complications are present. Arteriovenous malformation within this hemangioma cause increase in the pulmonary blood volume, causing pulmonary hypertension and high output heart failure. It can cause severe hypothyroidism due to massive overproduction of the type 3 iodothyroid dehydrogenase, which causes conversion of T4 to reverse T3, which is an inactive form. There are some associations we have seen. It can be associated with anemia, thrombocytopenia, consumptive coagulopathy, hypothyroidism, and pulmonary hypertension. Uniqueness of my case is it was associated with severe pulmonary hypertension in very neonatal period. An addition of both the combination drugs, steroid and propranolol, has to be required to control the disease. Thyroid hormone replacement was done due to severe hypothyroidism. There are some case reports and researches which matches our case, that is infantile hemangioma may be associated with pulmonary hypertension and heart failure. Also, there is a Journal of Pediatric Surgery report, infantile hemangioma along with hypothyroidism. So my take-home message is: look beyond if common causes of heart failure are ruled out. In case of presence of hepatic hemangioma, search for other vascular arteriovenous malformation. Despite benign tumor, the tumor may need medical surgical interventions, and biopsy feasibility should be done to confirm the diagnosis along with immunostaining. Propranolol is considered as a first-line therapy for this hemangioma, and severe cases may need combination therapy before going for surgery. These are my references. Thank you.
Is there any correlation of genetic background?
Nothing is very. No, it's not very fetal loss or no, it's not very argument there. So,
Many came with the loss
non-consensuous marriage.
Is there any particular genetic condition or aggression? The background of the disease, police association. If you cannot have thought of genetic counseling, it's an expectancy. Sorry. Again, basic clinical. Your first report showed and ejection fraction only 35. Right to deduct regurgitation is the right sided up. Ejection fraction is the left sided up. But you know, first echo, you never mentioned what is the pulmonary pressure, right? In the second echo, you showed it PAH is 56 almost up, right? What was the pathology in the heart? Is it due to hemangioma or high flow causing pulmonary hypertension going into ejection fraction failure? Okay, what is the primary problem in your heart? Because the presentation is heart failure. Is it a cardiomyopathy group of left-sided heart failure to start with? But your case shows that your problem is primarily because of high flow with pulmonary hypertension. And the last question is, what is the pathophysiology? You don't have to go basic. When the damage is to the liver, why the thyroid suffers? That explanation.
Thyroid profile you have done after for the prolonged jaundice. It's not the
Cause of the high TSH. Is it a separate issue or is it related to IHH? You said
it is related to IgH.
how? problem is in the liver. Why the thyroid is not good?
There is overproduction from the hemangioma. There is overproduction from the triiodothyronine.
Yes. Not right. And why is it absolute? Let us come to this point. Is it a right side? Is it a left side? Right? Was there any signs of a cardiomyopathy? As it looks like to be clinically first. Am I hearing?
So right side heart failure initially because
So you should have mentioned the pulmonary hypertension in the first report.
actually it was a screening echo in the past during diagnosis. The screening echo.
Your mistake. Thank you. Thank you.
The last case is an inevitable case of SAM with abdominal distension. This is the last case.
Good afternoon, respected judges. Good afternoon, respected judges, teacher, and my colleague. I am Dr. M.D. Babur Ali, presenting an inimitable case of SAM and good afternoon, respected judges, my teacher and colleague. I am Dr. M.D. Babur Ali. I am presenting a case, an inevitable case of SAM and abdominal distension. I am presenting a case, an inevitable case of SAM and abdominal distension. Hamid Sheikh, a 10-year-old boy, was admitted with chief complaining of generalized swelling for 1 month and pain abdomen for 1 month. In patient illness, the patient was apparently well 1 month prior to the admission, following which he developed gradual swelling of lower lips along with abdomen and face over a period of 1 month. It was also associated with swelling of the eyelids along with pain abdomen, which was gradually progressive and did not decrease on medication. In negative history, there is no history of jaundice, loose stool, vomiting, decreased urine output, blood in urine, burning sensation during micturition, bleeding from any side, shortness of breath, any infection prior to the episode, no history of blood transfusion, no contact history of TB, no prior hospital admission, seizure, arthritis, aphasia, or bone pain. In personal history, past history, and drug history, there is no significant history. In birth history, developmental and family history is not significant. Immunization history, there is no immunization except pulse polio. So from history, we can summarize that a 10-year-old boy presented with generalized swelling with abdominal pain for last 1 month. General survey, patient was alert, cautious, apathetic, generalized edema, moderate pallor, icterus cyanosis and clubbing were absent. Pulse rate is 120 per minute. BP is 50 to 90 percentile, temperature mild rest, respiratory rate within 20 per minute, no sign of distress. In anthropometry, height forage and weight forage below 3rd percentile, and BMI Z score is 0 to -1. This is a picture of the patient after 2 weeks of treatment. Systemic examination, GI system abdomen is distended. On palpation, liver is palpable 5 cm from right subcostal margin at the right mid-clavicular line. Spleen is just palpable. Ascites present and tenderness over the right subcostal region. Pigmentation on abdomen, steatotic dermatitis. Respiratory, CVS and CNS system is within normal limit. In summary, a 10-year-old boy who presented with generalized swelling for 1 month, pain abdomen for 1 month, hepatosplenomegaly, ascites, tenderness, right hypochondria, height for age and weight for age below the 3rd percentile. In differential, so we come in the differential diagnosis as SAM associated with abdominal TB or intestinal lymphangiectasia. In investigations in CBC, there is the decreasing amount of hemoglobin, but otherwise the picture is normal limit. In liver function test, there is mild increase of serum bilirubin on the 30th June. Serum protein and albumin is mild decreased. Urine dipstick test done and negative for protein and blood. Chest X-ray, nothing suggestive. Mantu test is negative. GL7 is negative. Stool occult blood positive. Upper GI endoscopy come out to be the normal. Ultrasound of abdomen done and shows the mild gross ascites and bilateral pleural effusion. Urine examination done and shows the albumin 1+, bilirubin mildly present. PT-APTT iron within normal limit. CRP and procal mildly raised. HbSAg, HCV and ICTC non-reactive. Acidic fluid analysis, there is no coagulum, cell count is 10 per cell per millimeter cube. KDA is within normal limit. No acid was bacilli on jejunum stain. SAG less than 1.1. In NCCT abdomen reveals the hepatomegaly with fatty infiltration, ascites and mild bilateral pleural effusion. Diffuse colon wall thickening with mild dilatation, retroperitoneal and mesenteric lymphadenopathy. In CCD abdomen, bowel wall thickening and edema with widely open patulous ICP and mucosal hyperenhancement. In terminal ileum, shows the gooseneck deformity in the ileocecal junction with mesenteric thickening and lymphadenopathy, likely ileocecal TB. Edematous large gut lobe, gross ascites with gross skin and subcutaneous edema and severe fatty liver. Colonoscopy done and reveals the multiple superficial and deep ulcers of varying size, mostly transversely oriented, with short segment involvement in transverse and ascending colon. Similar ulcers were present in cecum, ileocolic, valve, and ileum. Impression is probably ileocolonic tuberculosis. Histopathology examination done and consistent with ileocolonic tuberculosis. This is the picture of colonoscopy. Final diagnosis is ileocolonic tuberculosis with SAM with fatty liver. After stabilization with and control of infection by antibiotics, multinutrients, and nutritional management were given, ATD was started based on the clinical features and CCD abdomen, but liver enzymes began rising, so only ethambutol and streptomycin and levofloxacin were continued. Patient responded to the treatment for PM and became alert and cooperative by the end of 2 weeks of treatment of PM. Blood was transfused one unit, following which colonoscopy was done to confirm the diagnosis of abdominal TB and to rule out the Crohn's disease and other cause of protein losing enteropathy. LFT was done subsequently, which come to be the normal. Rifampicin was introduced, followed by isoniazid. Subsequently, pyrazinamide was restarted and streptomycin was omitted. ATD was continued for total duration of 6 months. Total hospital stay was 1 month, 10 days, and patient was discharged in hemodynamically stable condition. Take home message: the in same presence of ascites suggestive of tuberculosis. Thank you.
Sorry. No question. Excuse me, yes, please. Why there was pigmentation? I'll come to it next. Why there was tenderness in the right esophagus? Question number 3. Why fatty liver will some?
Sir, a decrease of protein, therefore,
Is it common in some?
yes,
Why tenderness in the right hypochondria?
liver is enlarged.
Every enlarged liver does not speak good. How much is it?
5 centimeter below the right supposed mark. Okay.
And final answer: when you stop giving the entity, what was the liver injury? How many times it was alanine aminotransferase was high? How many times? You remember? Otherwise, fine. When you stop what is D? Drug-induced liver disease. What is it in this particular case that was stopped to be real secondary? What they recorded.
Just 3 figures, so just part more than double.
That's it. And finally, this is also question. It's very difficult to diagnose Crohn's from in India. Is there a marker? Really? So finally, put it out that this is Crohn's. This is not. Is there anything like it in Indian support as of now?
Actually,
There's no 100% sensitivity.
If CVNet is positive, it is.
Can it have?
Tissue.
Can it go together?
Maybe, sir.
sometimes histopathology is also non-conclusive. So
Anyway,
now there is a Ames trial that those suspected cases of that there is suspicion TB or not.
consistent hygiene last and see which one. Thank you. Sorry.
Once there is the electric derangement, we start first decompression time. Bulldoze
We start bulldoze, then liver enzyme is increasing, then we stop it, and then we go for the second line liver processing.
Okay, then how will we introduce?
After
How will we introduce?
the liver enzymes become normal, then we gradually first we introduce decompression, then isomeragic.
Those training of 5 to 10 like this. In a stage wise or directly at Moodle?
Stage level.
Stage wise manner.
Stage-wise or directly.
No, no. When the liver enzyme is normal, then we start bulldoze.
And every 1 week interval we add, go add it.
1 week or 3 days then. After 3 days, you will go. Pause 1 week. Stop it 1 week. Then you start one drug. In 3 days interval, you will go.
Shut up. I'm the judge. So, just one small announcement, two small announcements. Both of them are speaker
Second. Sorry, we have a national respiratory check. National respiratory. 18. It will be on 17th and 18th of November.
আনমিউট করতে হবে, আনমিউট করতে হবে, শোনা যাচ্ছে না।